We're going to have a very quick Q&A, so I'm going to ask Dr. Berenson and Dr. Finelli to come on up and sit on the panel. And our moderator for this part is going to be Deb. She's going to read the questions. So, gentlemen, if you'd like to take a seat, and we'll get through as many as we can. We're going to have to cut this back because we need to get on track. So if you have questions, please hold them up, and I'll come around and grab them from you.
Okay. 5 minutes? Okay, we're going to do this really fast, okay? So the first question is for Dr. Finelli, and someone asked, I was told to keep my kidneys well hydrated. How much water should I drink per day? Quick answer.
Quick answer, if your urine is as light as a reminder note, those 3M Post-it notes, you're doing fine. It doesn't have to be crystal
Okay, that's
clear.
enough, thank you. Dr. Bjarnason. Dr. Bjarnason, the question was specific to Sutent, but let's widen it to the other drugs. How do you decide if Sutent, pazopanib, whatever, is no longer working? When is it time to switch drugs?
I mean, I think it's decided on the imaging. If you see an increase in the tumor, if the individual is on as high a dose as he or she is able to be on, and if there isn't an isolated area that is increasing at a time that everything else is okay, because if there are only isolated areas increasing, he would stay on the same therapy and have SPRT. And it's an extremely important opportunity. I mean, I think it is something that every oncologist has to ask every time if they are thinking that Sutent or any therapy isn't active, is the individual on the optimal, individually highest dose, and or is there an opportunity for SPRT?
Okay, thank you. Long answer, so we're not giving you any more questions. Okay, but thank you. So, Dr. Chu, the question for you is SBRT treatment a one-time or repeated? And while you still have the microphone, when it comes to the lungs, how do you manage tumor mobility and breathing for lung metastasis? So, one time or many, and lung metastasis.
So for a given specific target, it's one time, although that's a standard of care, but under research or potentially trial considerations, maybe re-radiation, but generally rule of thumb, one shot for one particular target. And then the second question was lung motion and movement. It's, as I highlighted before, the lungs drive and the movement or respiratory excursion of the diaphragm drives movement of all your organs in the body. So the technology or the means by which we manage or mitigate that movement, as I showed you for renal cell carcinoma, was actually derived from treatment of lung cancer, and that's immobilization with either vacuum compression or abdominal plate.
Okay, thank you. Dr. Finelli, you're not off the hook. The question is, there's two parts here. So how important is early detection and treatment of recurrent kidney cancer? And the second piece is, if it does recur and you end up with a solitary nodal mass in the abdomen, say 6 months after nephrectomy, what would you do with that?
I'll start with the second question first. I would consult with our medical oncology team, and depending on how well the patient is, if it's an isolated lymph node area, we would discuss the benefits of upfront surgery. And I think the philosophy currently is if we can remove something safely or radiate something safely, that's the route, and then medication after. The first question was...
How important is early detection?
Yeah, very controversial. You're going to meet some oncologists who feel that following patients with routine imaging often doesn't really change the natural history. I'm an optimist. My bias is if we find things early, it doesn't mean we have to intervene quickly, but we're aware of it, and we can then determine by its growth rate and if other sites are involved, the interventional strategy.
Okay, thank you. We have way more questions than we can answer in 1 minute. So what I'm going to do, I'll just handle one more, but I'm going to give each of the doctors the questions. get their answers, and then we'll make them available to you, hopefully sometime in the afternoon, or if not, on our website right after, because there are lots of really great questions here. There was a question about the CanCertainty website campaign that I don't understand, so whoever wrote it, please let me know. The final question that I want to leave you with is a great one to go into lunch. It says, is alcohol safe if you've had kidney cancer? What is the safe limit to consume per day? So I did not write this, but I have a vested interest in knowing what the answer is. So, do you care to, Dr. Finelli?
My understanding as regards kidney cancer, there's really no strong data. I think just it's general health. So, it's mostly liver toxic.
Okay.
I think that would be, safe and wise, moderation, small amounts.
So let's just take this across. Dr. Bjarnson, are you aware of a dose-limiting toxicity for alcohol?
Why not? There is a optimal individualized dose of alcohol.
Okay, an optimal to maximize. And for Dr. Chu, if we destroy our liver with alcohol, can you fix it?
No, I can't fix it, but I totally agree with Dr. Behrenson's assessment because I'm Asian and I have very low tolerance to alcohol.
Okay. Okay, I'm going to hand out the rest of the questions. We'll get you answers. Thank you.
So thank you to Dr. Finelli, Dr. Berenson, and Dr. Chu. Thank you, Deb.